It's my pleasure to introduce Dr. Mark Pimentel. Dr. Pimentel is a professor of medicine at Cedars-Sinai and a professor of medicine through the Geffen School of Medicine at UCLA. He's also the executive director of the Medically Associated Science and Technology, or MAST, program at Cedars-Sinai, an enterprise of physicians and researchers dedicated to the study of the gut microbiome in order to develop effective diagnostic tools and therapies to improve patient care. As a physician and researcher, Dr. Pimentel has served as a principal investigator or co-investigator for numerous basic science, translational, and clinical investigations of IBS and the relationship between gut flora composition and human disease. A pioneering expert in IBS, Dr. Pimentel's work has been published in the New England Journal of Medicine, American Journal of Gastroenterology, and Digestive Diseases and Sciences, among many others. Dr. Pimentel has presented at national and international medical conferences and advisory boards. He has also published numerous medical textbooks. These include the first ever atlas of high-resolution manometry and a recent text on the gut microbiome. He's a diplomat of the American Board of Internal Medicine, a fellow of the Royal College of Physicians and Surgeons of Canada, and a member of the AGA and ACG. Dr. Pimentel completed 3 years of an undergraduate degree in honors microbiology and biochemistry at the University of Manitoba, Canada. This was followed by his medical degree and his BSc from the University of Manitoba Health Sciences Center in Winnipeg, where he also completed a residency in internal medicine. His medical training includes a fellowship in gastroenterology at the UCLA affiliated training program. It's a true honor to have him on today. So without further delay, I'll turn it over to you, Dr. Pimentel.
Thank you. Sorry that there's such a lengthy bio these days, but I really appreciate you slogging through it. Very nice to meet you all. I'm super excited to be able to present to you today. I've done a lot of presentations in the last few days, so I've got a little bit of a voice issue, so try to bear with me as well. So what I'm going to talk to you about is sort of this concept of microbial overgrowth syndromes, and I'm now put this new slide into my deck recently, and I think what we are starting to understand is H. pylori is not an infection. C. diff is not an infection. Yeast in the mouth as a disease like thrush or esophagitis are not necessarily infections in the sense that they are always there waiting for something bad to happen, and then they overgrow, and then they cause the disease, such as thrush or C. diff colitis or an ulcer in the case of H. pylori. Because what's interesting, and I did some reading on this recently as part of a paper that we're putting together, 46% of 6-month-old infants have C. diff detectable in their colon stool or in their stool. So if C. diff is bad, why would it be present in 46% of infants? And so I'm not saying C. diff isn't bad. What I'm saying is it's there commonly, and it's only when it explodes or expands that it really causes disease. That's my point. And I think so this dovetails with the terminology SIBO, small intestinal bacterial overgrowth, because these characters are there, but they're there in moderate numbers or small numbers. And it's only when they expand that you get these illnesses. And that's what I'm really going to focus on today. But as we try to unpack small intestinal bacterial overgrowth, I know we're going to focus a lot on irritable bowel syndrome today. That's the purpose. And the reason that's the case is because IBS has been such a nebulous condition. It's been such a challenging condition to understand over these decades. And I'll get into a little bit of the nuance of that in here in a moment. But it's always important to remember that small intestinal bacterial overgrowth occurs when there is a slowing or stasis of the small intestine. The small intestine is not flowing beautifully. Think about it this way. You eat a meal, within 2 hours, 3 hours, the meal is done. You've absorbed everything you're going to do, and it goes to the colon for processing for stool. So it's a fast-moving river. The colon, a slow-moving river, like a swamp, more like, as it's packaging the stool. So that fast-moving river is generally clean. So anything that slows it down will mean it's like a plugged drain or a slow drain. You're going to get a buildup of sludge and bacteria, and that's one of the reasons. Another reason is immunodeficiency. So if you have HIV or if you have a combined variable immunodeficiency and you can't fight bacteria, you might get it. If you have pancreatic insufficiency, cirrhosis, where the defenders, the enzymes that break things down, the bile that's a detergent like soap, is gone or less, you're going to get buildup of bacteria. And of course, medications, which can slow things down. GLP-1s is a big one now. And of course, opiates, morphine. But getting back to the prime discussion is irritable bowel syndrome. Before I get to that, and this is really pertinent to the dietitian community, is that it's a myth that malabsorption is ubiquitous or universally a problem in SIBO. And it's not a myth in the sense that it doesn't happen. But let me explain. SIBO was first sort of described and became popularized in the 1960s. And at that time, we didn't have ulcer medication. The way we treated ulcers in the stomach that were bleeding is you had to cut the stomach out and then do a Billroth tube, create a blind loop. And these blind loop syndromes would produce a ton of bacteria in there, and that would be the bacterial overgrowth that was being diagnosed back there then, and that's how it was identified. But because of the rearrangement of the bowel, patients got malabsorption because all of a sudden you don't have a stomach. The food gets dumped into the small intestine and you malabsorb. And so some suggested that SIBO was part of the malabsorption and that SIBO was driving the malabsorption. And to an extent, it is because the SIBO of somebody who's had their Billroth 2 created is apocalyptically high compared to the SIBO that we're going to be talking about most of the time during this presentation, which is you can't say a kinder, gentler SIBO, but a non a SIBO that's not as destructive as the original descriptions of SIBO. So it's not the common SIBO we see now, because we don't do a lot of these aggressive procedures, is really a milder SIBO, and it doesn't necessarily mean malabsorption. The other thing that commonly is discussed is that SIBO is the colon bacteria moving into the small intestine. I'm going to show you data on sequencing, like next generation sequencing, shotgun sequencing of the small bowel, and that couldn't be farther from the truth because your small bowel in SIBO does not look like stool bacteria composition at all. It's a totally different thing than we ever expected. So stay tuned for all of that. But focusing on irritable bowel syndrome, and here's where we start to get into the meat of the matter. So IBS has always been defined by the Rome criteria. And the Rome criteria serve a very significant and important purpose in the 1980s. We didn't know how to define IBS. How could you develop drugs if you don't have a definition for your condition? And so the Rome criteria became an important definition to enroll in clinical trials, develop drugs, and then subsequently lead to a lot of the drugs we have today using those criteria for enrollment. The problem with the Rome criteria, it's all symptom-based. So 70% of Crohn's patients meet the Rome criteria. So Rome became expensive because it meant that you had to exclude Crohn's, you had to exclude celiac disease, and then if they meet the Rome criteria. But the other problem is Rome and the initial criteria for IBS were based on a premise that this was a problem with the brain and the gut. And that's where we started to go on the wrong track, in the sense that it's sort of like you have a big broken arm, and your arm is broken, and you feel the pain in your brain. So where's the problem? Is it the broken arm, or is your brain is just telling you it's too much pain? Let's turn the brain off. So this is the argument that we now make is the gut the problem and the brain is just telling you, hey, there's a problem. We got pain down there. We got, bloating down there. Or is it the brain that's overreacting to what's going on? And I'm in the camp that the brain is telling you what's going on in the gut, and the problem is primarily in the gut. But let's dig deeper. We now think that SIBO is, or ESO or EMO, and you'll get into the acronyms here in a moment, could encompass up to 60% of all of IBS. So if a disease is caused by something, you would imagine, well, maybe that it should be more than 60%. But remember, IBS is a wastebasket. You don't have Crohn's, you don't have ulcerative colitis. Okay, you meet these vague criteria. Here, you're in this bucket. And so that bucket contains a lot of different things. So 60% isn't a bad number. And in fact, if you look at peptic ulcers, about 70% of peptic ulcers are caused by H. pylori, not 100%, only 70%. So even in that instance where that microbe is causing ulcers, NSAIDs cause ulcers, et cetera, et cetera. So it's the same thing with IBS. 60% is sort of the rule we're seeing, and you'll see that 60% come up over and over again during my presentation. But SIBO, I told you, is caused by stasis of the small intestine. So if you really want to know the root cause, SIBO is just the manifestation of the stasis. But what is causing the stasis? What is causing the small bowel not to behave correctly in IBS, leading to SIBO? So the real root cause is down here. It's not the leaves up here where we're talking about SIBO, although they go together. So what I'm going to try to present to you is the root, and the root is food poisoning. So this is a meta-analysis of all the prospective studies that have been published looking at food poisoning, and then you develop IBS. So I was fine until I went to college, and on my spring break, I went to a Club Med place somewhere, got food poisoning. Ever since then, my bowels have never been the same. That's post-infection IBS, but that is IBS. And so what we now know based on this meta-analysis of all these prospective studies is that if 100 people, and I use this example every time I give this lecture, if 100 people went to a wedding and the buffet had food poisoning, meaning E. coli, Shigella, Campylobacter, or Salmonella, if it had one of those in it and 100 people got sick from that buffet, 14 would end up with IBS for an indefinite period of time after, which is a little scary. That's 1 in 7 people. But it gets even scarier because the most common bug in the United States is Campylobacter. And look at the chance for Campylobacter on the far right, 20%. So 1 in 5 people eating a buffet that has Campylobacter in it will develop IBS after that Campylobacter infection. So a little bit scary, but I'm going to try to walk you through it so it's not as scary as you think, because there are ways to mitigate this and to understand this better and maybe even prevent IBS in the future. So before I set up this next slide, what I want to tell you is that there is this notion that IBS is due to a psychological predisposition. So psychological trauma in the past, um, um, anxiety, stress, depression, all related to IBS. If you go back to 1972, the cause of heart attacks was stress. Because we didn't know. We didn't know better. We didn't know it was high blood pressure, cholesterol. We didn't know it was smoking and all those sorts of things. So the CEO of the company, of your company, gets a heart attack, is in the hospital for a month. That's how long they used to keep people in the hospital back then for heart attack, because they didn't have anticoagulants and all the things we can, get people out and without getting another heart, to try to prevent another heart attack soon after the first one. And so they were told, look, your job's killing you. You need to quit because it's stress. But now, fast forward to 2026, we don't dismiss stress in heart disease, but what we say is it's a cofactor. But the most important thing is the cholesterol, the steakhouses, the guy smoking cigars with his buddies because he's a CEO, and drinking alcohol, and all the bad things that go along with being a CEO that have nothing to do with stress. We're getting the same sort of situation here with IBS. Medicine has a tradition of, if you don't know what's causing something, stress might be the cause. Even with ulcer disease, that was the case. Stress ulcers, it used to be called stress ulcers, the ulcer in your stomach. Now we know it's H. pylori, as you know. But this study really kind of nails this concept down. This is one of my good friends and colleagues from Mark Riddle, who did this study with Chad Porter here from the U.S. military, and they looked at deployment to Iraq and Afghanistan in the 2000s. And these young men and women were going to Iraq and Afghanistan, and they were coming back with IBS. They didn't have it before they went. And so they looked at everything they experienced. So some people were at base camp typing on a computer, and other people were in foxholes shooting and experiencing, real life stress, trauma, losing limbs, wounding, killing other people, and witnessing human death and suffering. So if you look at the bottom half below the red lines, those are the stress that happens in war. And that had no impact on the development of IBS. The only thing that characterized the development of IBS is, did you get food poisoning when you were deployed? Did you have vomiting? Did you have diarrhea? Did you have diarrhea with an identified organism, et cetera, et cetera? So the point of this is it proves it's not stress. It proves it's food poisoning that's causing IBS. So now let's, shoot 10 years of work onto 2 or 3 slides. But this is we had to start with animal models of food poisoning using Campylobacter. Then we had to try to identify what in food poisoning could be causing the IBS. And we've come to a conclusion that it doesn't matter whether it's Shigella, Salmonella, Campylobacter, or E. coli. They all are very different, but they have one thing in common. They produce CDTB toxin. So after we did a study where we could cause IBS with Campylobacter, we took Campylobacter, we deleted the toxin, gave it to rats, and lo and behold, they didn't get the full phenotype of IBS. So we think CDTB is the cause. CDTB toxin from these food poisonings is the cause. And the way it works is you get food poisoning, Campylobacter, you get exposed to this toxin, which is secreted by Campylobacter, you form antibodies to this toxin, but part of that toxin looks like you. And U is a protein called human vinculin. And this particular vinculin is a protein that is on the nerves of the gut that help the nerves reach out and grab onto each other, like wires going to the switch on your wall to turn the lights on. And the most important cells where this is important is the cells that drive the cleaning function of the small intestine. So having antibodies to this disturbs those cells, reduces the cell number, and leads to stasis in IBS. And guess what stasis does? We talked about it earlier, SIBO. So now we're able to diagnose IBS for the first time with a blood test. You could measure these antibodies, anti-CDTB and anti-vinculin, and if they're elevated, they're more elevated in IBS versus Crohn's disease. So this isn't saying, oh, you don't have Crohn's disease, therefore you might have IBS. We're now past that. We're saying if you have these antibodies, you have IBS, and it came from food poisoning. So that's really a big shift, but it also means it's not in your head. It came from food poisoning. And so this next generation test, the second generation version of this test now meets what's called medical certainty. Anything above 80% is considered medical certainty for post-test probability for a diagnostic marker. Now you're going to say, well, specificity is 90%. That's great. But sensitivity is 56%. And you say, well, that's low for sensitivity. And I'm going to say to you, no, it's not. It's perfect. Because of what I told you, IBS is a wastebasket. Only 60% of IBS is SIBO and this notion of this path we're taking you on today. So the best sensitivity you can get if you took all comers of IBS is 60%, and you got 56%. So my point is this is not identifying IBS, it is identifying IBS, and it is the type of IBS that came from food poisoning. So bear that in mind. Now this gets exciting because now we can create IBS in rats by just injecting the CDTB toxin into their back. That's it. So they get the CDTB toxin in their back, and then 3 weeks later, they get a booster like a COVID vaccine. And look at the antibodies. They go way up in the rats because they got this injection. And because of that, and remember, we're injecting it not in their gut, but in the skin. And then they get diarrhea, and the diarrhea is proportional to the antibodies. So the higher the antibodies, the more the diarrhea. But here's where things get really interesting. We looked at stool. Stool microbiome doesn't change. Everything changes in the small intestine. So to break this down, the orange balls here are the microbiome and their compositional structure in space. And that's the control group. They didn't get the toxin. The green are the ones that got the toxin, therefore went to the wedding, got sick, but they're fine. They recovered. The blue are the one of the groups that didn't recover, and they developed elevated E. coli, which I'll tell you later in humans is SIBO, and that's a hydrogen-producing organism. And another group got elevated desulfovibrio, which is a hydrogen sulfide-producing cluster. And basically, the rats, from an injection of a toxin in their back, developing autoimmunity developed two different types of SIBO potentially. So they went down two different paths. Okay, the one final thing I will say about these antibodies, this antivinculin antibody, you when you do blood tests for markers for disease, right? So like an ANA for lupus, okay? The ANA is a marker of lupus. It is not the cause of lupus. But we think the antivinculin antibodies are a marker of IBS from food poisoning, but they are also the cause because they're actually causing the damage. And so it's really important to distinguish that because if we get these antibodies down, as this study we published last summer shows, 75% of those patients are improved versus those where the antibody remains elevated. Only 10% are improved in time as time goes on. So getting rid of this antibody could be the cure of IBS in the future. We just need to figure out how to do it. And we're working on that in the lab now. So let's skip this. And then breath testing is the next thing in humans. So now we're going to go to the human studies on SIBO. And this is a meta-analysis by Shaw. This Shaw is from Australia in 2020. 15 of the studies listed here are of high quality. And that's very important when you do a meta-analysis. But what I'm going to say is that if you do breath testing in humans with IBS, the chance of the chance of having SIBO based on breath test is much higher than healthy controls. But people argue about breath testing. For example, they say, well, we want to do glucose because glucose is more specific. I don't know how many of you know about the glucose versus lactulose problem, but if glucose gets absorbed so fast in the small intestine, if you get a rise of hydrogen from eating glucose, you definitely have overgrowth. So it's very, very specific. The problem is glucose only gets 3 feet into your small intestine before it's completely absorbed. So you're missing any SIBO beyond 3 feet, and you have 15 feet of small bowel. And other people were saying, well, lactulose, because it's osmotic, it gets to the colon faster, and the rise in hydrogen is due to arrival in the colon. So this study really is probably the most impressive study ever on breath testing dynamics, because what it did, and this was just last year, is it said, let's radio label the lactulose. Let's see when it gets to the colon. Let's see when the hydrogen rises. Let's do this in people who truly have SIBO because they have, surgery and all the things we talked about at the beginning, the old SIBO, where it's absolutely, blind loops and all those kinds of things. And then IBS, and then healthy controls. And what they found was the healthy controls were down here. Those are the black circles, solid circles. And then IBS broke down into two subcategories, a group of IBS that were normal and a group of IBS that were elevated. In fact, even more elevated than the patients with legitimate reasons for SIBO based on history. But what they found, 60 to 69%, so it's in that 60% category of IBS fell in this category. And what they showed was that the 20 part per million rise of hydrogen by 80 minutes, we use a cutoff of 90, meant that the hydrogen was coming from the small bowel because they actually measured transit. And then what they did is they treated everybody, not the healthies, but they treated everybody, whether they were positive or negative on breath test, and only the patients with IBS or these patients who had a risk factor for SIBO responded to the antibiotics, not the normal breath test group. So this really proves that SIBO it's important to look for SIBO and IBS to identify that 60 to 70% of patients who have it and then treat those. But now there's been culture studies. These are two culture studies, both from Europe. On the left, 43% of patients had greater than 5,000 coliforms per milliliter in their aspirates. And this, again, speaks to the 60% rule that we've been talking about this whole lecture. Now we go to sequencing. Now this is 16S sequencing, so a little bit older sequencing, but yet even here, If you use the cutoff of 20 by 90 on lactulose breath test, you get 84% specificity for SIBO by culture. And then if you look on the far right, the hydrogen producing enzymes, the mechanisms for hydrogen production in the small bowel correlate with the hydrogen on the breath test, meaning the hydrogen is not coming from the colon, it's coming from the small bowel. But now let's go to this study because this is the first, because we study the small intestinal microbiome and we're one of the only groups in the world that do this. This is the first paper published using shotgun sequencing of the human small intestine. So that is a big accomplishment, and specifically it was done to look at SIBO in this first study. And what we can see is that SIBO is not colon bacteria moving into the small intestine. It's literally two bacteria, Klebsiella pneumoniae and Escherichia coli, 18% and 28%. So I want you to think of it this way. Your small bowel microbiome, normal small bowel microbiome, contains thousands of different organisms. And when you get SIBO, those organisms are crowded out, and 46% of everybody in your small bowel are these two characters. Now, here's what I'm going to tell you about these two characters, Klebsiella and E. coli. They are Ferraris for digesting carbohydrates. They outcompete other organisms. They squash the rest of the organisms down because they are so aggressive at gathering food and fermenting that they basically take over once they start. And so that goes to this slide. A patient with SIBO, their microbiome has a glucose degradation potential 63 times faster and more aggressive than a healthy person. So you could sort of say they can produce hydrogen 63 times faster from a meal than the patient next to you who does not have SIBO. So those patients who say 10 minutes after they eat, I get bloated, yeah, they do, because they have Ferraris in their small bowel that are able to do this. And those produce hydrogen. And then there's also hydrogen sulfide producing pathways are also elevated in these SIBO patients. So breath testing and IBS and this whole area of breath testing was, I don't want to say it was controversial. Where it became controversial is when people started to say it was related to IBS. So the North American consensus said, look, everybody's got to be on the same page here. We got to assess these breath tests. We got to interpret these breath tests exactly the same way and follow the literature. And so these guidelines came out. Then the Europeans came along in 2021. Then the Asia Pacific group came along in 2022, and that includes Australia, then Brazil, and 2 weeks ago, Argentina. And so now we have the whole world essentially is saying, look, this is what SIBO is. This is how you do it. And SIBO and IBS are interrelated. And I'm going to take that one step further as I get close to the end of the lecture. But when you look at SIBO, we used to measure hydrogen and methane. The problem with hydrogen is it's a gas that is used as energy and fuel for methane production and for hydrogen sulfide production. You need 5 hydrogens to make 1 hydrogen sulfide by these organisms and 4 hydrogens to make 1 methane. And if you don't measure, these are the only 3 gases produced by the microbiome in the gut, except for carbon dioxide, which you can't distinguish from human production. But these 3 gases are microbial derived. But we now know hydrogen sulfide is causing diarrhea, methane is causing constipation, and so you have to measure these 3. But it makes bacterial overgrowth and this whole concept of microbial overgrowth syndromes complicated because you could have one of these or a combination of these, and that can affect how you treat patients. But let's go back to IBS. So this is the first study in history where you do a breath test, you do IBS different phenotypes, diarrhea and constipation, and the microbiome all in the same studies. So this is a diarrhea trial for an FDA drug or a drug where this trial was approved by the FDA, meaning an FDA approved trial, not an FDA approved drug. This is another drug in an FDA trial for IBS-C, but breath tests were done at the beginning. Forget about all that, but look at IBS-D, no methane. IBS-C, when methane's present, it is present in C and it looks like that. It's generally a flat curve and usually a pretty high number. If you look at hydrogen in these patients, the average IBS-D patient, not everybody, some fall below 20, the average is above 20, which is SIBO. And then hydrogen sulfide is higher in IBS-D versus the other groups. But this allowed us, measuring the microbiome allowed us to understand, is the breath test just a rough marker or is it an accurate marker? And it's an accurate marker because what it does is it not only tells you you're producing too much methane, which is associated with constipation, it tells you how much methanogens there are in the small bowel. And the key methanogen for methane in humans is M. smithii, Methanobrevibacter smithii. And you can see that at every time point during the breath test correlates with the amount of M. smithii in those patients' stool. So it's really important that you understand the breath test is quantitative. It is correlating to your microbiome. We did it again in the small bowel. So this is a very cool study. So this is the Reimagine study, part of the Reimagine study. Here, we took the patient's breath right now. 20 minutes later, they're in the endoscopy unit. We're scoping them. We're getting juice from the small intestine, from the duodenum, and then we shotgun sequence it and we look for methanogens. And what we find is that the amount of methane on the breath test correlates with the amount of methanogens in the small bowel as well. And the most important methanogen, accounting for 63% of the correlations, is Methanobrevibacter smithii. So again, this is the same culprit that we saw in the other study. So what does Methanobrevibacter do? Well, it produces methane. And so the question is it the bug or is it the methane that's causing constipation? And what you can see here in this study, methane gas was infused into a live animal model of transit, and those animals showed a 59% slowing of intestinal transit every single time they got methane. But look what happens to the guinea pig ileum musculature when you put methane in the organ bath. This is a beautiful peristalsis. This is when methane and oxygen are in the bath. So methane causes the gut not to be paralyzed, but to spasm so things don't move. And it may be responsible for some of the pain that these patients experience as well. So methane spasms the gut, non-peristaltic, and that's what slows things down. And now there's meta-analyses. This is a meta-analysis done looking at methane relationship to constipation. If you're methane, you have more constipation and less diarrhea. Makes sense. This is a study from Stanford where they did wireless capsule transit studies, and they show if you're methane, your capsule transit is slower. Again, same story with methane. Then we did the same thing with hydrogen sulfide. So hydrogen sulfide in the breath, and then scope them 20 minutes later, grab the juice, look for the hydrogen sulfide producers. And sure enough, the hydrogen sulfide on the breath correlated with the hydrogen sulfide producing organisms in the duodenum. Why are we going through all this effort? Because there's been some comments about breath testing. It doesn't really tell you what's in the small bowel. It doesn't really do this. It doesn't really do that. But it doesn't really do that because nobody ever looked. Nobody ever did those studies. And now we know that the breath test is correlating with those organisms in the small bowel, and that the breath test is now more validated than ever in history. So now let's take one more sort of push at this. And this was a 6,000 patient breath test study, home breath test done across the US, 3 gases. And what we can see is a number of things, but what I want to show you principally with this one is that if you do glucose, you miss people with SIBO. And not only that, when we looked at the severity of symptoms like diarrhea in patients who were negative on lactulose, if that's the test they did, and negative on glucose, if that's the test the doctor chose or the practitioner chose, the patients who did negative on glucose had more diarrhea symptoms, meaning those negative breath tests on glucose missed some people, whereas lactulose, they didn't miss much because the diarrhea scores were much less. So my point is glucose misses SIBO. It may not miss EMO or intestinal sulfide overproduction as much, but it definitely misses the hydrogen-producing SIBO. But here's where things got really interesting, again, showing hydrogen sulfide is correlated with a more severe phenotype of diarrhea. And this is a radar plot. And what we're now starting to think is that hydrogen sulfide is almost the most important gas. We're getting to that point because hydrogen sulfide is way more toxic to you than methane or hydrogen. And when it's present, you have diarrhea no matter about the other gases. And when it's present, you have more severe diarrhea, pain, urgency, and everything is more severe. So it's really the driver of severity in patients with IBS. I'm not going to get bogged down with this slide too much, except to say that in this Reimagine study, when we grabbed the breath and 20 minutes later we did the scope, we took biopsies as well, and we're able to see what you are doing because you have hydrogen sulfide in your gut. And your gut is extremely unhappy to the point where if the hydrogen sulfide is high enough, the cells are dying. If the hydrogen sulfide is in the middle range, your mitochondria are losing function. You're secreting fluids, which makes sense why you have diarrhea. Serotonin's up. The serotonin receptor is up, which causes more fast transit, more liquid secretion, etc. So we're able to piece this all together now with hydrogen sulfide being a very important culprit in IBS. So it boils down to really IBS breaks down into three microtypes in this group of 60% of IBS. You have the methane side on the right, which is associated with constipation. The predominant organism is Methanobrevibacter smithii. You have the traditional SIBO, which is E. coli and Klebsiella in the small bowel, not colon bacteria, it's E. coli and Klebsiella. And then on the left is intestinal sulfide overproduction. And we've now started to identify the cast of characters there. So we're really jumping ahead and trying to find better ways to treat these now that we know the characters. So now let's go into treatment. So rifaximin was FDA approved in 2015. These were the two primary phase 3 trials. And the FDA ultimately approved rifaximin, saying, okay, IBS could be a microbiome disease. Rifaximin is affecting the microbiome in a way that makes IBS feel better and stay better for a period of time. But the exact reason for the microbiome issues weren't altogether put, the pieces weren't all put together as they are, as I'm showing you them today, but they were already starting to come together. But what we learned in Target 3, the third trial before the FDA approval, was if you did a breath test during that trial, and you never looked at the breath test, you just treated everybody, 44% of IBS patients will get better. But if you looked at the breath test and the breath test was negative, only 25% got better. But if the breath test was positive, 56% got better. And if rifaximin made that positive breath test now negative, meaning got rid of the overgrowth, 76% met the FDA endpoint. So this is an important study because it says that IBS is not IBS. In IBS, there's a group that has SIBO. And if you know who that is, you're more likely to respond to the antibiotics. Here is a meta-analysis of using rifaximin in any SIBO patients. So it doesn't have to be IBS, but it could be anybody with SIBO. And again, a lot of studies, 32 studies, shows that it works. And this is a study similar to the previous one I just showed you, the 32 studies, but now taking only the studies in IBS. And if you do a breath test in IBS and it's positive, you're more likely to respond to antibiotics. I put this slide in, and actually yesterday, our second paper of harm in IBS got published, which isn't too dissimilar to this one. But what I want to highlight is the number of people who get better from tricyclics before one person has to stop the drug because it's causing them a side effect is 2.3. That's super high. I mean, a lot of side effects is what I mean. You could get 846 patients better with rifaximin before a person would even stop that drug during the 14-day treatment. So rifaximin is extraordinarily safe as compared to the other drugs in this category. And the new paper yesterday, when we compiled even more data on rifaximin, it turns out that it's not 846, it's infinite because placebo was more harmful than rifaximin. And so couldn't actually calculate harm because more people dropped out of placebo than dropped out of rifaximin. So that's more testament to rifaximin even than this. But how do we treat IMO, intestinal methanogen overgrowth? This is the only study we have. It's a double-blind study. We did a lot of on the methanogens to try and figure out what cocktail of antibiotics could work for these archaea. They're not even bacteria. Methanogens are not bacteria. And it turned out neomycin rifaximin was very good in the test tube, but let's test it in humans. And in humans, constipation was more diminished with neomycin and rifaximin, and it really depended on getting that methane down. For hydrogen sulfide, we're still getting the feel for this, trying to figure it out. But what I do in my office is I give bismuth, Pepto-Bismol type products with rifaximin, and when I do that, then I get the best outcome for hydrogen sulfide, and we're seeing some really good results with that. And then for those of you who don't know, elemental diet is out there. This is a new elemental diet that's it tastes better than the old elemental diet. I published the first elemental diet study in 2003 with an older product. It's meant for tube feeding, and it just had it just was difficult to take for 2 weeks. We did about 1,000 patients over time, but at least this new elemental diet, the way it works, it tastes better. The way it works is it restricts calories to the bacteria of the gut because it gets absorbed so quickly. That's how elemental diets work. And you can see the methane level in this 30-patient trial before and after elemental diet, and the hydrogen level before and after elemental diet. And in both cases, the average patient was now normal, and the symptoms all improved statistically. Now, in the last few slides here, as I'm concluding this presentation, what I wanted to do was talk to you about CSO6, which is it's a new molecule. So now that we know the organisms that are part of these microtypes, we can target the organism with small molecules. This is a small molecule that goes into the binding site of the enzyme that produces methane. And what we see in rats is that when we do that, the rat's water weight of stool goes up and the methane in their stool goes down. So if we can block methane, we can cure constipation and not have to use antibiotics. This is just blocking methane production. In a similar way, now that we know the cast of characters for irritable bowel syndrome with diarrhea, we can treat those with specific antibiotics or combinations. But what we learned studying the small bowel microbiome is that there's these bacteria, this crew of bacteria, many of them live up here in the sort of the free fluid layer, and many of them live, half of them in fact, live down in the mucus where rifaximin can't penetrate because rifaximin is hydrophobic. So could we break the mucus, allowing rifaximin to get to everybody bad and make patients better? And so we did the first double-blind randomized control trial of rifaximin here versus rifaximin with NAC, which is N-acetylcysteine, at even a lower dose of rifaximin. And what we see is that rifaximin in 15 patients per group, so it's a small pilot study, they're getting better, but not as good as rifaximin plus NAC. The patients are really getting better with addition of NAC. So we're right now in the middle of a double-blind randomized placebo-controlled trial run by Cedars-Sinai, no drug company, and what we see is that this trial is hopefully going to get us a new product that may be better than rifaximin alone, because now we understand the microbiome. So in my final two slides, this is the Indian consensus statement. So we haven't had a consensus statement or a guideline in irritable bowel syndrome since 2019, 2018, because there's no new drugs. And when you do consensus statements, you really want new drugs on the market to be able to have an impact or a good statement. But what they did, because this is in 2023, they took advantage of a lot of the data I showed today, but obviously in 2026, the amount of data is much more. But even then, the guidelines are now saying IBS and SIBO go together, methane and constipation go together, and food poisoning is related to irritable bowel syndrome. So this is now the way we believe a good chunk of IBS is caused by food poisoning, leading to overgrowth, and methane leading to constipation. And finally, the world is changing in IBS. We're moving away from the notion that IBS should be diagnosed with Rome criteria, because criteria don't work really well. Because, as I said, 60 to 70% of Crohn's patients meet Rome criteria. And so looking at these antibodies, for example, you can see in this paper, they do discuss it in the abstract even, that going towards biomarkers really are the next wave of irritable bowel syndrome, legitimizing this as a disease. And then SIBO is a very important part of this process. And this is a paper by Mayo Clinic, really starting to sink our teeth into SIBO's real. We need to get further along in this understanding of SIBO so we can get better treatments. And so this is what we do for SIBO. SIBO, I give rifaximin. For ESO, I give rifaximin and Pepto-Bismol. Intestinal methanogen overgrowth, I give rifaximin and neomycin, sometimes sub out metronidazole. And future treatments are coming, and we talked a little bit about that. So in conclusion, so we have time for questions. IBS is a disease. It's a disease because now we have an organic basis for a good chunk, probably 60% of IBS. Food poisoning causes that chunk, and probably works through the development of SIBO. Blood testing can now diagnose and risk stratify IBS. I can't tell you how many patients get a test, it comes back positive and said, I knew I had something wrong. I knew it wasn't in my head. I knew when the doctor told me just relax, that it's not, don't worry about it, that it's, you just need to take it easy, that wasn't what was going on. Three-gas breath testing is the most validated breath test in history now, because never have we validated breath testing against duodenal aspirates. Hydrogen sulfide is turning out to be maybe the most important gas of all. And because we now understand the cast of characters that cause these different subtypes, new therapies are emerging. So I thank you for your time and attention. And I don't know, that was a mouthful and an earful. I hope you got something out of this.
Thank you. That was truly fascinating. I'm sure everyone out there has learned as much as I did. To our audience, I just put the link to download your CEU certificate in the chat. You'll also get an email from me with it later today. We've got some really great questions, so let's dive right into these. The first comes from Jessica Rucroft, asking about the 2019 CAG clinical practice guidelines. On IBS, asking you if you can share any kind of insight or preview into whether updated IBS guidelines might be coming that would recognize the role of SIBO in IBS, and any preview you could share insight into that.
Yeah, I think what we're seeing is a lot of review articles that are saying SIBO and IBS are going together. I think we're seeing international guidelines that are bringing this together. Honestly, as much as I hate to say it, drug companies and new drugs drive guidelines in a sense, because when you do a guideline, you do what's called grading. And I'm not trying to get too complicated, but there's a grade system that's applied to look at the evidence for a drug. And so when you do the grading, you give the drug a grade. The problem is we don't have any new drugs, and therefore the grading will not have changed since the last time this was done. And you cannot grade diagnostics. You cannot grade relationships to causation. There is no such structure. There is no such grading system for that sort of thing. So we're sort of stuck until a new guideline comes out and new drugs come out. So maybe this new drug, or a couple of these new drugs that we're talking about at the end here, will fuel the fire for another guideline. So we'll have to rely mostly on, these review articles.
Very interesting. Thank you. We've got another question from Ava asking about the evidence for treating patients with antimicrobial or herbal functional protocols. I'm sure all of our clinicians out there are receiving this question quite a bit from patients. So the extent you can offer support as they field those inquiries, I'm sure would be much appreciated.
Yeah, so I mean, I could do an 8-hour talk on SIBO these days because there's just so much to cover. We didn't cover a lot on diet. We didn't cover a lot, even though this is a a group of dietitians. I'm not even sure I should be educating you. You probably know more than I do, but um, but yes, there are other alternative ways to treat SIBO, oregano oil, berberine. There was a cocktail from Johns Hopkins University using berberine as the sort of the predominant factor or active ingredient, and that worked as well as rifaximin in short term. Allicin or Alimed, which is a sort of a commercial name for a product, is effective for methane short term. People use horse chestnut, which the product, and I know you don't want to use too many names of products, but that's in the Atrantil product. That I do use that occasionally. But my goal is to use the things in this presentation first. And then if they fail and the SIBO continues to be a problem and the breath test is continuing to be abnormal, I start to depart into some of these other branches. And we do find like things like Allison only work temporarily and then the methane comes back. So maybe for a month you feel better. So I'm not sure that's a long-term solution. And so these are the challenges that we have with some of these alternative therapies.
Thank you. Yeah, certainly much more to present on and cover in future talks. Here we have a question from Hallie asking, what can we do for our patients with mixed symptoms of constipation and diarrhea?
Yeah. So I always think of mixed as basically the same thing. And let me sort of explain that. They talk about men having less IBS than women. That's not exactly true. So it's probably 1.8 women to men, but it's not a women's disease. And I hate that term because the women aren't a disease and they shouldn't be attributed to a disease, but there is a higher proportion of women with these conditions. And it could be because women tend to get more autoimmune diseases, rheumatoid arthritis and other autoimmune conditions, again, for reasons we don't exactly understand. Uh, but when we look at the diarrhea side, men are 2 to 1 to women on extreme diarrhea. And on the constipation side, extreme constipation, like the worst of the worst, women are 8 to 1 to men. So women tend to manifest constipation more, men tend to manifest diarrhea more. So my men with methane, for example, they tend to be mixed IBS, even though methane causes constipation. And the women with methane, they're very hardcore constipated because women tend to gravitate in that direction or be more susceptible to the effects of methane. So everything's on a spectrum. So I think of mixed as it's all part of this process. It's just the overlap of the two conditions.
Thank you. Yeah, great. Very interesting. Here from Laura, we've got a open-ended question as well, for your thoughts on refractory SIBO.
Yeah. I mean, one of the things I don't cover a lot on is, again, diet in this particular presentation, because I was focusing more on mechanism of action and how, pharmaceuticals can be effective. But refractory SIBO, of course, we'll try some of the alternative therapies. Diet becomes very important. There's two ways that I use diet, and things like enzymes, is in the maintenance of the remission. So in other words, if rifaximin works, what I want to do is prevent the need for rifaximin again to the best of my ability. So that would be dietary interventions. I don't tend to use low FODMAP because of the long-term effects. I use low fermentation diets or other mitigation agents, even prokinetics, to try and prevent the relapse of the SIBO. And then I might use those in instances where they're refractory to treatment. I'll use diet, a heavy effect on diet, or I'll use elemental diets to try and correct them, and then again intervene with a long-term diet to try and prevent rebuilding up of the bacteria by using low fermentation eating techniques.
Fascinating. Thank you. Here we have another question from Rama asking about, any potential long-term health outcomes or negative effects of not treating SIBO and IBS and how to think about that.
So there's data from the 1980s connecting methane to colon cancer. And now that went away for a long time. And now that methane is becoming a hot topic again, there's data coming out and emerging, bringing that back up and seeing that signal again. So the question is, does methane lead to colon cancer? I can't tell you wholeheartedly that's true. but there are people working on it. There is data on this. Is methane associated with Parkinson's? The answer is yes. There is some associations. Harvard's working on that sort of thing. And so maybe because, as many of you know, Parkinson's starts with constipation 20 years before Parkinson's develops, and methane causes constipation. So people are starting to see if the methanogens have some role in the development of Parkinson's. So all of these are all early days. Please don't get all worried about these things yet, but people are looking at how these bugs are affecting. And hydrogen sulfide organisms are apocalyptic to you, and we're just at the beginning days of understanding that, because those can have effects. And we know hydrogen sulfide is linked to the development of ulcerative colitis. It's also linked to the development of colon cancer because it is so toxic to the epithelium that the epithelium is stressed chronically, and maybe that leads to colon cancer. So stay tuned because there's a lot coming out soon.
Yeah, thank you. Wow, really interesting areas to be exploring. We've got also quite a few questions asking about probiotics, both during and then following treatment to try to support remission.
Yeah, so first of all, prebiotics are highly fermentable. So I wouldn't use that either to treat or to keep in remission because they tend to bring the SIBO back or to fuel the SIBO. Probiotics is challenging because in the microbiome work we've done with Reimagine that I don't show here, lactobacillus, which is the predominant probiotic, is associated with obesity. We've shown that now. In animal models, we've shown stuff like that as well. And then in lactobacillus is associated with unhealthy aging, and that's also a very big problem. So and lactobacillus is a disruptor of the microbiome, just like E. coli and Klebsiella. So if you take more lactobacillus, lactobacillus is good for your colon, but you're not taking it by enema, you're putting it in your small intestine, and it's very bad for the small intestine. It's basically wiping out all the good populations. So I don't like probiotics. I don't like them in SIBO. I don't like them for maintenance. There are a couple of studies out there that say that Bifido might be able to prevent SIBO from coming back. Not large studies. I'm not impressed yet, but so I'm not saying no, but I don't do it. I don't do it.
Yeah, fascinating. There's definitely a lot of different conflicting data out there on it.
Yeah.
Being asked for also a couple resources where we can point providers and patients to education on the low fermentation diet, if there's anywhere you'd highlight.
So I can, Jocelyn, I can send you our low fermentation eating little pamphlet give to patients, and then you can distribute it to this list if you have the names of these folks.
Thank you.
I'm happy to do that. Yeah. We don't
Sure.
have a website. We don't sell anything from low fermentation. It's just what we've been doing low fermentation for 25 years, longer than low FODMAP. We just never commercialized it in any way. It was just what we did.
Thank you. Great. Um, we've got some other questions here also on the topic of GLP-1s and potentially their role in increasing the risk factors for that stagnasis that you're describing, and what kind of relationship maybe you're seeing in practice.
Yeah, GLP-1s are cause SIBO. They do. I didn't know until last year at DDW when they started to show some data. And the problem with GLP-1s on top of that is that they're so delaying of stomach emptying that you can't do a breath test very easily because you drink the lactulose or the glucose, and the glucose will just get absorbed from the stomach, won't get out of the stomach, and the lactulose won't get out of the stomach. So the breath test becomes a flat line and basically useless. So yeah, GLP-1s are having a dramatic problem. And because they slow the intestine down, remember what I said before, you slow the intestine down, E. coli and Klebsiella build up. And we see that also in the studies from DDW, not from our group, but from others.
Fascinating. Yeah, certainly a lot more to learn on that front as well. Well, we are at time, so I want to really thank you for coming on today, sharing your immense expertise with us.